All right, welcome back to another episode. We're going to dive into probably one of the most fun topics for me is treatment, and not just like what we can do hands-on. IASTM, red light therapy, taping, cupping, everything else we could possibly do,
All of the
adjusting,
above.
but also exercise and how we can view exercises as treatment. We do get into the weeds a little bit about like what does an adjustment do, which I know we kind of talked about already. What it's important is anything, any of those modalities more important than the other? And then where does exercise fall into that? We also get into why we choose to take longer with our patients, and that kind of feeds into why we don't take insurance. But all of this and more just for you. But yeah, it's going to be a fun episode, so hope you enjoy. All right, so when we're starting with treatment, I think the first most obvious thing is like, what is an adjustment? What's a mobilization? What's a manipulation? What's the difference between the kinds of manipulations we can do? Because that's what chiropractors are classically known for. We're going to get into all the other fun stuff that we can do, but let's start with the basis. What's an adjustment, Maggie?
There are many ways that you can define an adjustment. It depends on what you're thinking of, I guess. In the most common way that people think of an adjustment is that big crack, that big, like when chiropractors say they're moving bones back into place.
But are we moving bones
back
into place?
We're not moving bones. That's kind of the most common, which is the HVLA, high velocity, low amplitude adjustment, where you're seeing like chiropractors jump on people. That's where we get the memes on social media and all that type of stuff.
The fun Halloween's upon us soon, and like it's going to be the skeleton snapping in half and all that fun stuff.
Yes, and that is just all an adjustment does, the way I see it, is it's reintroducing movement back into a joint that maybe isn't moving as well as it can.
I think that's the best way. Like, so when we're looking at the pop, the clicks, the cracks, in which I don't get offended when someone's like, hey, can you crack me quick? I'm like, yes, I can. Like, I'm not going to belabor the point, right?
Why would I say no?
Why would I say no? But like that crack doesn't always have to happen. When we're just thinking of an adjustment, moving things a little bit better. I used to hate this analogy, but now I've kind of leaned into it, pun soon to be intended. I heard it explained by a chiropractor long ago that like we're kind of riding a tree that's growing sideways. We can move things back 100%, but like if I hook my F450 up to a tree, like a little sapling, and try to yank on it, I'm gonna either snap the bumper off if it's a really big tree, not a sapling, or I'm gonna break that sapling, right? It's like we want to gently guide things into more optimal movement. That's all really an adjustment is. There's no, in my opinion, there's no like huge soul benefit to that. Like we need to adjunctively add things on top of that, and that's just my stance on things. If we get better mobility of a joint, how's it going to stay there? And this is what I think our treatments differ in, because we also work into the muscles, the neurological tissue, things like that, which that's where we're going to get things to stick. And that goes to our next subject. What other treatments do we do?
We do a lot of like soft tissue muscle work with our hands. So just like manually working muscle tissue. We have cups, scraping tools. So instrument assisted soft tissue manipulation.
Instrument-assisted soft tissue mobilization or manipulation. It's the M is up for grabs.
Whatever we want to use the M for, that's it.
Or we could think of it as an instrument-assisted neurosensory modulation device, because really what we're doing is modulating the mechanoreceptors, and we can get really nerdy and talk about how cool like Pacinian corpuscles are and Merkel's discs,
how that's playing into all of it,
which is actually really interesting.
It is very interesting. So a lot more of like that type of treatment where we're focusing mainly on muscles, and then we do a lot of exercise-based care.
So not to like hit all of those things, but let's talk about just overarching theme of manual muscle therapy, whether that's with tools, whether that's with cups, or whether that's with our hands. Again, like if we're going to move something meaning adjust something, mobilize something, a joint or something like that. We're introducing mobility into the system. Then we work on the muscles. We're also introducing mobility into the system. So if we add mobility on top of mobility on top of mobility on top of mobility with a patient who needs stability, we're not defeating the purpose, yet. But like if that's all we're doing, that's where we kind of create this dependency of the person. This is where you see, I know myths and misnomers was last episode, but like this is where people do have to continue to come back.
And they're kind of stuck in that cycle of needing to come weekly, and this is where, like, monthly.
Somebody who always stretches something that needs more stability is never going to get better, right? Just doesn't make sense. So this is where the exercises come into play. So we can mobilize something on the table, we can manipulate something on the table, but getting them more stable, aka stronger, into, dare we say, even like an antagonist tissue. For example, quads and hamstrings or biceps and triceps. if my biceps is super tight and I'm walking around like this, well, we can adjust things, work through the muscles with cups, things like that.
We need to find some stability and strength through that tricep.
100%. Yep. So with all of those treatments at our kind of discretion and warrant, because it depends on which person needs what kind of modality and tactic, right? This kind of leans into, why do we spend so much time with our patients? And is there anything wrong with the classic chiropractic visit of being 5 to 7 minutes?
There's, I guess, nothing really wrong with that. But is the patient getting everything they could in that visit? Probably not.
Yeah.
It's getting like a piece of the puzzle. So we're getting just that little bit of mobility. And that's where, like, okay, we aren't really fixing a problem here. We're just kind of helping it not get any worse.
And potentially get better. Like, I don't want to play awfully in the sandbox like I did when I was a kid, but like, if you go into your, dare I say, standard chiropractor, and they're good at their jobs, like the one thing I always talk about with chiropractic students is they'll start bashing these other chiropractors. I'm like, no, like Dr. So-and-so has been in business for 40 years.
And they're getting people better.
Trust me, he would not be, or she would not be in business for 40 some years, or even 20 years or 10 years or 5 years if they weren't getting people better.
Yes.
Like, they're clearly doing a good job at their jobs. But describing a job, like we describe it a little bit differently. If we're doing a good job at our jobs, we should be seeing less and less of our patients. And that's where I think the adjunct of things, and therefore the time of sessions, kind of runs its course, right? Like, you can't get one without the other. Our goal is to try to show people how not to see us and how not to be dependent on us. And that takes time. With that, like, we can talk about insurance too. Well, let's talk about that right now. Insurance doesn't pay for time, right? How many times have you had a patient come in and like BS with you for a little bit about what's going on, not just about life and kids and things like that, which happens too. But then all of a sudden they start like crying. Or like really get emotional. Not that we're their therapist, but like that's part of therapy. Like the biopsychosocial approach, and like if they can overcome that or rationalize it or even just question it, and then we don't have to have an answer for it. Sometimes that's super beneficial. And insurance doesn't pay for that.
No.
Now, granted, I don't want every patient to cry with me and give hugs or anything like that. But sometimes that happens, and that there's a necessary space for that. Also, insurance doesn't reimburse us very well for things like manual muscle therapy, corrective exercises, rehab.
All the things that we are doing.
All the things that we do.
With every single patient. Most patients, if not all patients.
Yeah, and so like, therefore, it would be kind of shooting ourselves in the foot to take insurance. With that non-insurance and kind of our approach, and back to the time idea, I don't know about you, but like I'd say in a normal 30 or 40 minute visit, it's usually like 50-50 or 60-40, depending on which ratio of that 60-40 we spend on the table or treating things manually, adjusting things, etc. And then the other 50 or 40 or 60% of the time, it's about half and half kind of thing. We spend out on the floor going through corrective exercises, or even re-examining every session, like, hey, how does this ankle feel? How does your shoulder feel? Like, what's different from last time? Let's go through your old exercises. Which ones are getting too easy? Which ones are getting, or have you've noticed becoming too hard or painful? And that's where I think tailoring that approach to the person specifically in front of us is just, it's what I like doing. Right?
And it makes it more fun for me.
It does.
I enjoy it.
It's not protocolistic where you like think of these patients as like machines, where if I plug in X, we're going to get Y. Like, it's not that easy.
No.
Like, somebody's, Joe's biceps tendonitis is different than June's biceps tendonitis. It's different than Josh's biceps tendonitis. Like,
everyone's going to have a different approach, I guess is a weird word of putting it, to their injury.
Right.
And a different
mechanism, a different timeline, a different importance. Like, what are their goals? And like, if somebody just has shoulder pain, but they do nothing, they probably wouldn't see us because that's not the demographic that we see, but like they have zero interest in getting better. How much better do we have to get them? And like, we're going to try our hardest, but like, they don't really have that buy-in with that. So it makes it challenging, right? Speaking of challenging, complex cases. I hate saying that we kind of like specialize in complex cases, but because we like looking deeper at things, because we like, and dare we say, we're passionate about tailoring the approach to them, we end up seeing a lot of complex cases. Or I think I get in trouble with this because like sometimes I almost make straightforward cases more complex because I start looking, Well, but
You're
like,
looking deeper at something. Like I've had someone come in with knee pain and I'm like, well, let's look at your foot. And they're
yeah,
like, where are we going with
but like
this?
knee pain is a great example, right? Like knee pain, knee is the dumbest joint in the body. It's supposed to go
Stupid.
straight forward and backward.
Yep.
It's not supposed to rotate much more than 5 to 7 degrees. It's not supposed to laterally tilt much more than 3 to 5 degrees. So like,
Yep.
if it's doing any of those things, it's probably not the knee's fault.
It's coming from the ankle, hip, foot, anything up
somewhere
or down
else.
the chain.
Yep. And therefore, we have to make a pretty straightforward case complex,
Yep.
which takes some education to the patient of like why we're looking at their ankle, why I'm not touching their knee, why I'm looking
Yeah.
at their hip, things like that. But like with those complex cases, I think we get a lot of benefit from having the mindset of like looking elsewhere.
Yep.
Right. With that said, like, do you have any, I mean, any off the head cases that are super interesting to talk about? And like, I mean, we could talk more about knee cases. I love them. Cases that would be important to kind of bring up of like a good example.
I had a complex case that I did end up pushing off to a different provider because it was so complex that it was kind of out of my wheelhouse. Patient came in with like bilateral thoracic outlet syndrome with compression of both subclavian veins, which doesn't make sense because her symptoms were only on the left.
Okay.
So like, does that even play a role into anything? Because they're both, is that even causing the issue? And like nothing was helping. She had gone to see 5 different providers. She'd seen a chiropractor, seen PT, vascular specialist, all these things, and just nothing was improving.
Yep.
And she comes to me and she's like, what can you do? And I'm like, well, I'll throw what I can at it.
And that's
and like
a random spin-off to that. Like, let's bring up the idea of like foam rolling or like any other exercise we could possibly recommend, like clamshells or something boring like clamshells or foam rolling. When somebody's been recommended by 6 other providers, 8 other providers, the same exercise,
Yep.
and all of a sudden we want to recommend the same exercise, like it's not going to be that much different. Like
no.
If it hasn't worked in the past, it's probably not going to work in the future. And if it was going to work, it probably would have worked by now.
Yeah.
We have to think outside the box or push that box to figure that out. But it's cases like that. And I like that you admit, I mean, not that we're too proud to like admit like, oh, we have to refer to somebody else. Like when it's out of our wheelhouse, send them out.
There were some things that like I was really helpful with. Like she really loved the manual therapy and wanted to get like deep muscle work done. And that was super helpful and beneficial. And I was someone who could provide that. But then she found a really specific thoracic outlet syndrome specialist PT who does it every single day. That is what they do physical therapy in. And I said, go there.
Yeah.
I am like running you through the ringer of the exercises that I have in my brain that I know. Go there.
Yep.
And I still get a call from her every once in a while, like, I really need some muscle work. Awesome. I'm happy to be that gal.
But you did the right thing and said, like, let's get you in the right hands, right?
Because at a certain point, like, I can't keep doing that to myself either. Like, running through my brain of, like, did I do this right? I don't know.
Tasking. It's mentally tasking. What I was going to say with that, and kind of on that same point, is like, you ended up referring this person out and sometimes still see them from what it sounds like. You still did as much benefit as you can. You still thought outside the box to not just refer to another generalized PT or another generalized this or another vascular specialist. Like, again, if those things were going to work, they would have worked by now.
Yes.
So like, it's still kind of a kudos, pat on the back to you. My shoulder mobility sucks. Kudos to you of like still thinking outside the box, still pushing that envelope a little bit further. I'm working with a complex case right now of a guy who his low back went out, just run of the mill low back tension, saw a chiropractor and got worse, dramatically worse.
Yep.
And super interesting case and a lot of biopsychosocial hurdles to jump over. Mm-hmm. Biologically, he has an injury or an inflammation. And we found out after the fact, after about 2-3 visits, we ended up getting an MRI of his low back and found a small disc bulge, right? Nothing that would explain the symptoms in his neck and arms, which is almost worse than anything right now. And basically this chiropractor had him come in, run in the middle low back pain, adjusted everything, the flying 7 as we know it. And now he has like debilitating arm weakness and neck pain and shoulder tension and things like that. And so it's an interesting case. And like, there's probably every other visit, I kind of allude to him like, hey, I'm more than happy to stay on your team. I'm going to continue to dive deeper. But if at any point, this is kind of like a first date, like a Groundhog's Day of first dates. Like if at any point you don't want to go on a second date with me, AKA not come back for another session, like I totally understand.
Which is kind of what you have to do with a complex case.
Yeah.
Like, if I no longer become that person for you,
I'm
then
doing all I can.
Send me on my way. You get on your way. Well, call me if you need me someday.
But I think like the openness of having that conversation
People
with patients,
appreciate it.
they're like, thank you, because now I don't feel guilty. Like now they can come and tell you like, hey, I heard about this. Would it be worth trying? Like you can almost work together, which is the point of, as weird as it seems to say, like our relationship with patients is like any other relationship. But imagine dating somebody who's always right. Like that's a toxic relationship. With a relationship with your provider, you should be open to have a conversation and question things, and
it should be safe to say that,
or things like that. Like
disagree, bring up how you're feeling.
100%. And that's where I think complex cases get fun in the win category, is like when you create that environment, that open environment, to have a win-win situation, because we like winning, we like getting people better, they like feeling and moving better. That kind of creates that, or fosters that environment. So sticking with the vein of treatment, we kind of get into this nuanced category of like, which one's more beneficial? And I think this is a mental hurdle for me sometimes, because I'm like, hey, I could work through with my hands, I could work through with tools, I could cup this, I could floss this, I could put some red light therapy. Like, which one's the most important for this person at this time? Is there a better tactic at a given time, or for a given person, or for a given diagnosis or symptom?
Yes.
Okay, go
Question mark. It depends on the timing of the injury. I think if someone is in really big acute pain, like big flare-up of pain, muscle work, soft tissue work is probably going to be my go-to first before
versus something
exercise or like getting them up and moving, or even an adjustment. Because if they're in this really seized up, like high guarded pain, an adjustment is not going to feel great. Depending on the type of adjustment it is. If we're thinking just HVLA adjustment, I'm probably not going to do that to someone in high level pain. Yeah.
So like with that, I totally agree. Like in general, even we can even extrapolate this question into flow of like, what do we do first, then second, then third? Like, is there a recipe of how to get things better? And I think sometimes there is. When somebody's in that high threshold acute pain, like let's say 9 out of 10 pain, you reach for their shoulder and they kind of like flare back. Like we need to numb that down first. Cupping, red light therapy.
That is all going to kind of gaslight the brain into being like, okay, we're safe. We're in a good space.
Way to use the gaslight word. We're so modern and hip. But 100%, like if we can dull that down and mitigate that pain threshold so that we can get movement, but then also in that same vein, like I always tell patients, like going back to the adjustment, what is that? Like, I'm only going to move this as far as your body's going to let me. If you are so rigid and tight, which we just agreed upon, assessment and feeling and everything else, that these muscles are on high threat spasm right now, your muscles are stronger than I am. I know I'm jacked, but like, it doesn't matter how hard I could drop the rocks people elbow on something. It's not going to move because your muscles are so guarded. We have to calm them down first. If they get calm enough where we can do something, great.
If they don't, then we might not need to do something.
Then then maybe we have to wait. And like, I hate saying that to people, but at the end of the day, I'm a chiropractor, not a magician. We can't get things better in one visit all the time. So,
but if someone's coming in and they're 3 weeks, 4 weeks, 6 weeks post injury and they're feeling great and they're moving great and they're back to their like regular routine, then we're going to spend most of our time doing exercises, challenging that, seeing what other pieces we're missing in those movement patterns, or what little movement is still causing pain, because maybe there's something, but it's really specific. So how can we tailor an exercise to kind of get that tolerance back too?
Yeah, that's one of my favorite questions with like, when patients start getting 50, 60, 70, 80, 90% better, even 100% better, is I don't really believe in the idea clinically and business-wise of like maintenance care, rather like performance care. Like, hey, you feel 100%, you have no idea what actually 100% feels like. Like, let's get you what you think is 101%, because right now, I know you feel pain-free, which that's why you're saying 100%, but you're actually living at like 80%. Like, you're missing that next gap, right? Like when people start getting better, let's say after 2, 3, 4, 5 visits, whenever they start feeling like really better and we start working more exercises, one of my favorite questions to ask them is like, what can't you do, right? If we're talking knee pain, shoulder pain, like what movements in your workout, what movements in your day-to-day are causing this? Because like,
how can we get you back to that?
Right.
So there are some people who come in, they're like, well, I can't overhead press, but I just don't do that. And I'm like, wouldn't you want to?
And that's
like,
sometimes
what if you have to put something on a shelf someday? Like,
sometimes they don't want to, and that's where our job is to like inspire them. Like, you need to. Like, where do your coffee mugs sit? Up here? well, you have to grab those.
Yeah. Like, yeah, you can't overhead press 15 pounds right now, but what if that decreases down and then you can't grab something off the shelf?
And
like, let's tackle this now.
That's what I love about exercises is basically take somebody's threshold of movement from like here and like, okay, think about it like as crutches. And I think we've used this analogy before, but like, let's start with crutches and all of a sudden we need a walker and then we need a wheelchair and your threshold just keeps getting less and less. And then we're bedridden for the rest of our lives. I don't think anybody would agree like that's the proper pathway to go. And that's where exercises, rehab, whatever we want to call it, kind of pushes that threshold and combats it head on. We start increasing that threshold. And that's the fun part of our job. Like getting people to feel stronger, more resilient, more hard to kill kind of thing. Like that's fun.
And that feels good for them. It's so empowering to be able to do something new, especially if you came in and you're like, I'm never going to bring my arms above my head again. And now you're doing that just like, without thinking about it. That's awesome. But that's
where like the easy answer of like, oh, well, it hurts to run. It hurts my ankle to run. Stop running. But I'm a marathoner. Like that's my identity. And that's where like, I hate when providers, or I'll hear like people come in and they'll say, well, my other provider, doesn't matter what the profession is, just told me to stop doing that. It's like, do you want to stop doing that? No? Then what's our only other option? We have to face it head on.
We have to figure out how to continue doing that.
So then that kind of circles us back to exercises. Like, do you think, and I mean, we're biased towards exercises. What I'm hearing, if I was listening, is like, we only do exercises and we kind of favor that. Do you think exercises are better than any hands-on therapy or treatment on table treatment kind of thing?
Sometimes, yes, that's the case. I don't think that every patient responds as well to exercises we would like them to. Like in my head, I want to say, yep, 100%. But if I had people coming in and I just gave them exercises, which I've seen a lot of people who've seen providers who only give exercises and they don't see any progress with it. So I don't know. I don't think one is better than the other. You kind of need both.
They need to complement each other. I do think like movement is medicine, though.
Which
like,
it is completely, and I think you do need movement to get anywhere. But I don't think it is the end all be all.
If the habit or the pattern or how you're using this piece isn't what it should be, and I'm not saying that we need perfect posture. I hate the idea of perfect posture, perfect form, or perfect positioning. Like I should be able to pick up a pen off the floor with the worst deadlift posture as possible and not blow up my back, right? But that goes back into building resilience and tolerance. Like we should be able to move freely without pain, ache, tightness, etc. So no, I don't think one of anything. Like any possible treatment is better than the other, including adjustments. Like going back to the chiropractors that only adjust and it's a 5 to 7 minute visit, like that's still better than nothing. And maybe that gets you, like maybe that quick session gets you to go out and run, gets you to go out and lift, gets you to play with your kids, gets you to lift that coffee mug up. Great. But you have to do that. Like, I think a lot of people's problems would get better if they just got more strong, right? Like, and more, more resilient. So,
but I think sometimes to get them to do that, you need the other side of things.
For sure. And that's why we have jobs.
That's why you can't say both.
That's why we have jobs, Maggie. It's fun.
That's all we have for you today. Thank you so much for chatting with us, listening to us talk all things treatment, different modalities we can use, different things that we use in the clinic every single day. That's what we have for you today. If you have any other topics you want to hear us talk about, we'd love to hear them. Comment, like, subscribe.
All the fun things.
Follow. Do it all.
All the things. Thank you.